I think it is fitting today on the 35th anniversary of our founding of the Hemlock Society of San Diego, when I was a wee child, of course, that we have the honor of hearing from a man who has done more for medical aid in dying. We call it MAID, medical aid in dying, than anyone in the last decade, I would say, and that's Dr. Lonny Shavelson. I can't tell you how pleased I am that he has taken over the reins of organizing aid in dying, particularly for California, but also around the country. Since 2016, as you well know, we've had legal medical aid in dying, or MAID, for the 40 million of us in California, and also for the citizens of 9 other states and the District of Columbia. Still, most people have no idea about this law. And for many of us, there's confusion. How do we find a doctor? Or if you are a doctor, what do you do? What are the medications? How do you get them? How do you give them? How do you take them? Where do you get them? Then what happens? If you're a doctor or a patient, how does this law work and how is it accessed? Dr. Lonny Shavelson began the idea of establishing uniformity in this practice in a conference some of us attended pre-COVID in February 2020 in Berkeley. From that success, which was a very successful conference, we were all so pleased to be there and be able to talk about this subject. The American Clinicians Academy for MAID, which is ACA MAID, Lonny's organization, now a nationwide resource with a distinguished board, nationwide board, concerned with pharmacology, medicine, nursing, research, and many related disciplines. For Californians, Lonny now has a website, a clearinghouse, educational videos. Lonny is, by the way, a very good photojournalist, and research into the effects of medications and more topics that Lonny will tell you about. Maybe you don't need to know this, but I first encountered Lonny Shavelson through Derek Humphrey, our founder of the Hemlock Society. And I would say also the founder of the Right to Die movement, Derek was, and still around. I was on Derek's board when he sent us Lonny's beautiful 1995 book called A Chosen Death, in which he gently, specifically, using his medical and photojournalism skills, depicted the chosen death of 5 people. Said one reviewer, and I have to quote this because it's so touching to me, written with sensitivity and compassion and accompanied by Shavelson's poignant and often haunting photographs, A Chosen Death shows us the anguish, determination, and dignity that can impel the dying to contemplate suicide, as well as the powerful emotion impact this decision has on family and friends. This was 1995. A prolific writer and social commentator, Lonny has written at least 4 other books on subjects relating to drug addiction and sexual and cultural diversity. I cannot think of a more appropriate speaker to celebrate our 35th year than this humane, talented, sensitive man with diverse interests who has organized medical aid in dying into a useful, practical, scientific part of medicine that will ultimately provide a peaceful death for so many of us. Dr. Lonny Shavelson.
Wow. Who were you talking about? Was that me? Let's see, can you all hear me? Just some nods so that I know that I'm existing. This is a little bit strange always doing these by Zoom, and my apologies for not being there personally, but here I am in my home office. And thank you for inviting me, and congrats on 35 years. That's scary and wonderful at the same time. I'm going to switch now, and let's see if I can share my screen, and then you can all nod at me if it actually works. So I'm going to smooth that over there. And well, maybe I'm not. First, I'm going to do this, and forgive the technical pause. Participants can now see my screen, it says, and now let's make my first slide come up. play from start. Make sure I can move. Yes, I can. Okay. Ignore the fact that I changed that slide. All right, I just need some affirmation from somebody just to nod that you're seeing what I'm supposed to be seeing. Okay, we're good. You can see me, you can hear me. Thank you. So I am presently the chair of the American Clinicians Academy on Medical Aid and Dying. You'll be hearing a bit more about that, but I'm going to take you on a little bit of a strange deviation for just a moment. So permit me. At the beginning of this pandemic, or the plague, as I tend to refer to it, I decided to get a pandemic puppy and to have a dog to get me through the plague. And interestingly, I sort of listed all the things. I've had many dogs in the past, although none for 10 prior years. And I was kind of looking for a big dog, the kind that I used to have that would jump on me and put its paws on my shoulders and had a beard just like mine and was wonderful in a flowery garden and the perfect dog. And then reality kind of hit and I went to the pound, and that's what was the last dog available, a dog with behavior problems and kind of shy and certainly not big. It's 10 pounds, called Corvida. And so as I was leaving the pound that morning with the new dog, one of the very, very astute people who worked there said, you know, you're looking a little bit more hesitant than maybe you should be here. And she said, let me give you one piece of advice, which is that love the dog that you have, not the one that you wanted. And strangely enough, as trite and pithy as that sounded, it really affected me in kind of learning to live with this dog and just understand this is the dog I have and I need to work with that, not live with fantasies. And so let me completely destroy that into a metaphor. Here's the aid in dying ideal. Not necessarily my ideal, but in talking with people about various things that they wanted, this is what I've learned, is that people without a terminal illness should also be allowed to have medical aid in dying based on their severe suffering or a variety of other criteria. Advanced directives should be useful so that people with dementia and other mental issues or mental capacity issues, so to speak, would be able to access medical aid in dying by an advanced directive. Assistance to a person who has physical capacity, the choice of medications, they could be oral medications, intravenous medications, like in Canada, gas inhalation even, and that we should have no state boundaries and so much more. People should be able to access medical aid in dying should they wish and when they wish. But this is what we got. We got the patient must be terminally ill with a less than 6-month prognosis. Just having suffering is not enough according to the law that we have and all laws across the country. Advanced directives are not allowed. You can't say you want this in advance and then get it 2 years later. You must have physical and mental capacity at the time you take the medications. The only medications we have, and this is a major, major drawback, as you'll see, is usually by oral medications. You have to swallow them, or there are other ways that I'll talk about, and that you can have no assistance whatsoever in the ingestion, although preparing the medicines and all that are there. So here's what the reason that I'm showing you my adorable dog. No comparison directly intended. One thing that I had to decide is, as I've been involved in this issue since 1995, in 2016, when it came to California, is will I still be advocating for a better law, a different law, the ideal law, the perfect dog? And or as a clinician, will I work towards making medical aid in dying as we have it, according to the legislature, make it the best medical aid in dying that we can possibly have, clinically, for the patients, for the clinicians, for everybody. Let's work with the law that we have and make it the best we can. And this is my way of explaining the role of me and the Academy, is that we have spent the last 6 years, and you'll learn some details about that, really learning how to work with the laws across the country that we have, while other advocates work on changing things and making them better and different and all of the rest. I'm now in the business of being a clinician, a doctor. That's what I am, and really, really working on making this the best aid in dying that we can have. And so I will leave you with that idea and then kind of talk more about what's happened to medical aid in dying in California, as an example, since about June 9th, not about, since June 9th, 2016. And you're going to see that name 2016, that year come up a lot while I talk here. And you'll see why. But we're going to compare 2016 and go through the evolution to now, where I think we've made revolutionary changes in the clinical practice of medical aid in dying. So let's go back with a brief history of aid in dying time. Aid in dying in the United States is 25 years old. That is a puppy. That's really, really a small amount of time in the history of medicine that we in this country now have access to medical aid in dying, starting in 1997 in Oregon, going to 2022 now. And here's a little bit about how that happened. October 27th, 1997 in Oregon, they didn't pass, they went into effect with the Oregon Death with Dignity Act, which had been already passed for a couple of years, but there were legal wranglings going on. And these were our forebears. The people in Oregon, the clinicians, the patients, and the legislators and the lawyers and everybody, for the first time, there was medical aid in dying, and they had nobody to look to who had done it beforehand in this country. Other countries had done it, but with very, very different laws. So these folks, our forebears, had to invent fire. They had to figure out the caves. They had to do cave paintings. They had to do everything that somebody at the beginning of a process does with really no precedent whatsoever. And they are our heroes, and we stand upon their shadows. However, there were some limitations to what could happen at the very beginnings, one of which was that the only guidance that they had been handed down as laws. There was no clinical experience. Nobody had taken care of a patient. And so what they learned early on was to focus on the laws. That's what they were told. The patient had to be over 18. You all know this list, right? Less than 6-month prognosis, capacity to request 2 doctors, lots and lots of forms. And so the focus for the initial period in Oregon was really on the legal practice. And the clinical practice was sort of like, once we get the legal down, then we just write a prescription and the patient dies. That's easy, which it's not, as we've learned. So one of the other things that was happening in Oregon at the time is Oregon's not the biggest of all states. Population at the time of 3.5 million. Over the first 10 years in Oregon, 564 prescriptions were written, which comes down to 56 patients a year, 2/3 of whom actually took the medications. So clinical knowledge, when things were moving with that small a number of patients, did not advance rapidly. It did advance, but clinical knowledge advances slowly when you have so few numbers and so little bedside experience for 10 years. And so that slowly evolves and things move along. And then we go into this sort of accelerated period that starts in 2009, 11 years after the Oregon law, actually 12 years after the Oregon law. And then Washington State comes on board and the population accessing aid in dying triples immediately. Montana, Vermont, you all see this story, 2016, California and Colorado at the same time, and on and on and on. And here's why I think 2016 is a turning point, is because simultaneously in that year, California and Colorado came on, increasing the population of people living in aid and dying states by 44 million people. And so because of the numbers, not the dedication, but the sheer numbers, finally, things could start moving forward. There was enough clinical experience and bedside experience that the clinical practice, we had the laws since Oregon started in 97, but the clinical practice really didn't take off fully until around 2016. So that now you have 22% of the US population, 3.5 million people in 1997. Now we have 73 million people. And that's the big change that I'm going to be talking about. To a certain extent, it's a question of population dynamics. So aid in dying clinical standards and evidence-based care, data collection, and actually looking at the science of medical aid in dying, as well as the clinical experience, has moved forward and evolved to the point where we had so many people and so much experience. We organized a conference in 2020, only 3 years ago, 2.5 years ago. And in the conference that Faye mentioned was at UC Berkeley on February 14th and 15th of 2020, with 300 clinicians, not the politicians, not the legal advocates, not even most of the advocates, although they were there. The people on the stage and the people who were learning were clinicians talking about how to take care of patients at their end of their lives who are considering medical aid in dying under the auspices of what was in the laws of the time from all over the country. At the end of this amazing conference, a first event in the history of our country, was the announcement of what I now head, the American Clinicians Academy on Medical Aid and Dying. You'll be hearing more about that, but we have become sort of the clinical go-to place for medical aid and dying information, investigations, all sorts of things that go on there. So aid in dying evidence-based medicine since 2016 on the lower left has now come to where we are in 2022, where we are advancing and advancing rapidly. And that really, if you look at what would have been before 2016, it certainly would have increased, but not at the velocity that we've seen in the last 6 years. To begin with, I'm going to talk about the pharmacology and physiology of aid in dying and what improvements we've made to that very substantially. But before I do that, I want to be very, very clear. I'm going to be sort of sounding like this really cold-hearted person at the moment, because I'm going to be talking about how do we stop somebody's heart as if they're not connected to an entire patient. We're going to talk about the chemistry. But don't forget that by the time a patient comes to the point where they are taking medications to die, they have been through our palliative care. They've been through hospice care. We've looked at the social and the spiritual and all the aspects and really spent time with these patients over a significant amount of time before we get to the question at hand, which is how do we stop their heart at the date and time that they wanted us to? So if I'm going to be sounding very, very cold about this part, realize that as a clinician, we've gone through a lot of stuff with our patients before this. The first question that comes up often when I talk about aid in dying pharmacology is, why is this so complicated? If you look at that list that I have here, that's 7 changes in the pharmacology of medical aid in dying in the last 6 years. We have just barreled through improvements and unimprovements and trying to figure this whole thing out. Why is it so complicated? Everybody tells me, look, can't you just give somebody an overdose of medication and they die? And the answer is, well, no. So to understand what I'm talking about, why this is so relatively difficult, I'm going to take you back a few more years than these 6 years to the Cambrian era, which is, 520 million years ago, when the archaeologic evidence shows, the fossil evidence shows that that's when there were the first time of having tubular, contractile, muscular, electrical hearts. So 520 million years ago was the beginning of the evolution of hearts, and they have evolved very, very specifically since then to be amazing organisms that keep us alive now for, lots and lots and lots and lots of years. And the first major advances in aid in dying pharmacology were about 6 years ago. So hearts have a big start on us. We are sort of lagging behind the 520 million years of evolution that we've been dealing with. The heart then is by necessity an extremely functional, resilient organ. And at the time that the patient tells us, I'm ready to have medical aid in dying, our job is to stop the heart. And we have to do it comfortably. To add to that, the constant in all states is some variation of the term ingestion and self-administration, which means that we cannot use the best tool that clinicians have. When you go to the hospital, they don't just give you a pill, they start IVs, they use injections. We cannot use any injections by law. Nothing, not subcutaneous, not IM, not IV, intra-abdominal, nothing. The medications must be ingested. So not only do we have this problem of the evolution of the heart and the resilience of the heart, we also are facing one hand behind our backs that we can't use the tools that we would like to have otherwise. Going back to Oregon in the beginnings, the pills that were used, the capsules in this case that were opened up into powder, was mostly Seconal. There were other medications, Nembutal and others used, but we're going to focus on Seconal as an example. They were using in Oregon at the beginnings sedatives alone. One medicine, it was a sedative. The idea was to get the patient asleep and then go on. So we have to look a little bit to understand this process about how do sedatives alone work. First of all, they're sedatives. When you take a huge dose of sedative, which is the overdose that's being used, 100,000 milligrams of Seconal, the first thing that happens is you go to sleep, usually within about 2 to 5 minutes. And it's very, very consistent and effective in getting patients to sleep. As the medication keeps being absorbed and the blood levels rise, the patient's sleep becomes a coma. It deepens so deeply that you're no longer asleep. You're now in an unconscious coma, unaware of surroundings. As the brain gets more and more sedated by this, and the respiratory center of the brain, mostly in the brainstem, also enters the coma. You get respiratory suppression. And here's where it's important to know this, is that there is no direct effect on the heart by Seconal. It doesn't damage the heart. It doesn't stop the heart at all. What it does is it stops breathing, hopefully. The breathing creates a lack of oxygen. The lack of breathing creates a lack of oxygen. And the heart stops because of a lack of oxygen. There's actually nothing that the Seconal does directly to the heart whatsoever. You'll see why that's important. Quickly, how well does secobarbital work? If we look at Oregon data from 1998 to 2018, you can see that the median, those statisticians in the audience know that the median is not the mean or the average. It is the median where things go in the middle, but it looks pretty good. 25 minutes from ingestion to the time of death. That is really, really good. I will tell you that. But the data has to be looked at a little bit better. So what's really important is not where the middle is, but what the range is. And the range of Seconal deaths ranged up to 104 hours. That's 4.3 days. And I will promise you that 4.3 days from ingestion to death is not what the patient was asking of the clinician in medical aid in dying. The expectation and the desire was not to die 4.3 days later in a coma while your family is all sitting around taking care of your body. The expectation is to die within minutes to hours. So Seconal in and of itself was problematic because of the range, how long people would take to die. What we learned from that experience is that sedatives alone reliably induce sleep and coma. No problem with that. They don't reliably stop respiration, because if respiration was stopped, the patient doesn't live on for days, they die within minutes. And so we know that Seconal did not reliably stop respiration. Nonetheless, that's what they had in Oregon. So for the first 11 years, Seconal was pretty much the medicine of choice. And it was, unfortunately, saying to someone it works most of the time is probably not the best medical care, but that is what they had. And I want to honor them for that. They were the pioneers and they were moving along with what they were given. Along comes, here's the year again, 2016. In Washington, Dr. Carol Parrott and Dr. Bob Wood at End of Life Washington, with some others, thought, you know what, Seconal is getting expensive. It's problematic in the first place. It's hard to find. Let's see if we can do any better. And so what they thought of was, well, if Seconal only stops respiration, what if we also put into the cocktail some medications that also damage and stop the heart? Realize, of course, that by this time the medications are working, the patient is unconscious. Before any heart medicines, you don't want to stop somebody's heart while they're still awake. So the whole idea was to create a mixture of medications. And what they came up with was called DDMP2. It had a sedative, just like Seconal. It put the patient to sleep really, really reliably. It was Valium, diazepam, and morphine at huge doses, and equally effective to Seconal, but also equally unreliable, as was Seconal. And so they added in two medicines that are known to slow the heart, digoxin, and a beta blocker, propranolol. So this was the first major advance in aid and dying pharmacology after the first 12 years of aid and dying existence in the country. I'm sorry, it was even longer than that, 2016, 20 years. And so the idea was that if you continue to breathe, even at a low rate, digoxin and propranolol would slow the heart down until it was barely breathing, barely beating, and stops. Along came at this time me in 2016, and for the first time, we were looking at DDMP2, the newer medication, and I wanted to know, how does this stuff work? And what evidence do we have it works? What really is happening in the body? So I started carrying around a little portable handheld EKG monitor. It's really the size of my hand, and a pulse oximeter. And with patient's permission, I was putting this small EKG on them and sitting by the bedside and watching their hearts and watching their oxygen levels as they were dying, to try to add some knowledge to this process that really up until then was, well, these seem like toxic medications, we'll give these. And the first thing that we realized after not too long was the idea of slowing the heart may not be the best way. So here's a patient of mine, and here is the EKG strip from that patient. You can see that this heart is beating roughly at about 5 to 10 beats a minute. Very, very, very slow. But the patient's comatose and doesn't have many oxygen requirements. They're not running marathons. The patient's unconscious, lying there quietly. And oddly enough, a heartbeat of 5 to 10 minutes can allow the patient to live for many, many, many hours before the heart actually stops. So the problem with slowing the heart turned out that when you looked at the physiology, it may not be the best approach. Rethinking this, Carol and I and some other people started talking, and we thought, what if we took the opposite approach and turned everything around, and instead of slowing the heart down, we speed it up. And so we swapped out the propranolol that slows the heart for amitriptyline, a medicine that is known for being very, very toxic to the electrical system of the heart. And you can see here that by speeding up the heart, really, really a fast heart rate, the heart electrical system destabilizes, the heart fatigues, and then you get flatline and the patient dies with a much greater efficiency than what we were seeing with the prior medications. So this was the beginning of adding some hardcore science and understanding the physiology to figuring all this out. At the same time, for the first time, we were collecting really good data. So every one of the vertical lines that you're seeing on this graph represents a patient who we collected the data on or were at the bedside with. And the height of the line is how long it took them to die after taking the medications as we changed these protocols. And what you can see is that the time to death improved drastically, as did the reliability. These tall outliers like you're seeing at the yellow section really don't exist, what you're seeing in the lower right section as the medications improved. So we're pulling in these very, very long deaths to the point where they're extremely rare or non-existent, and the time to death is improving. I'll explain why that's important in a moment. Not to take you, I could talk about pharmacology all day, as you probably guessed by now, but not to take you too much there. We're going to fast forward to the present. The present medications are DDMA-PH. There are now 5 medicines in this cocktail. We now have the highest efficiency of any medications that have existed since the beginning. And why? What is there about these medicines? In this cocktail combination, you get the very rapid onset of sleep and coma. It is 100% reliable. Everybody gets to sleep. I'll change that. There are extremely rare exceptions, probably patients who shouldn't have gotten the medicines in the first place, but that's a different conversation. Improved average time to death, pulling in the outliers. Long deaths are extremely, extremely uncommon now. And now, why do I keep emphasizing why time to death matters? Well, for the patient, it probably doesn't. The patient is unconscious from about 5 to 10 minutes in. The patient is deeply unconscious and unaware of anything, to the best of our knowledge, at least in a non-spiritual sense. But the family and loved ones and friends and who's ever waiting are at the bedside waiting for actual death or heart stopping to ensue. And if they wait 1 to 2 hours, well, that's a pretty successful death. They get to sit there, be with their loved one as they die, and experience the death in 1 to 2 hours. At about 2 to 5 hours, well, that's kind of acceptable. But what I've seen at the bedside is that people are starting to get restless. They're concerned. They have childcare issues. They need to get out to their own families. There's all sorts of stuff going that starts around 2 to 5 hours that says, it's not wonderful, but it's acceptable. But by 5 to 10 hours, you've got a whole lot of restless people in that house. They're hungry. They need to do other things. They're really, really worried that something is going wrong. The patient's not going to die. And it's what I call a problematic death, and greater than 10 hours is an unacceptable death in the research and investigations, the way we've classified things. So time to death actually does matter. Here is the data. This says 311 patients at the top. We're actually well over 400 patients that we've tracked now. And we can tell you very, very specifically that if you're going to take these medications as a patient, and the family is going to need to know this, about 80% of the time the patient dies within 2 hours of taking the medications. About 16% more die within the 2 to 5 hour window. So we're now at about 95.6% of all patients die under 5 hours, which is pretty darn good compared to what's happened in the past. And then we have the outliers. About 3% take 5 to 10 hours. Not wonderful, but not really awful terrible. And then we have this 1% of people who last about 10 to 19 hours. It's extremely unusual. We've heard some anecdotal reports of somebody going over 20 hours, but those are usually due to mistakes in the medication, not the way the medications work. So that's the data that we have right now. Let me move to this 1.1% to explain that these are the problems we're still trying to solve. Who are these patients? Why do they go out that long? And what can we do to fix it? And as it turns out, the answer probably doesn't lie in the pharmacology or getting better pharmacology, because as you know in medicine, if something goes wrong, we always blame the patient. And so the most common reason a particular patient had a prolonged or complicated aid in dying death was not because the medicines were bad, it's that the patient's intestinal tract wasn't up to the task of getting the medicines into their bloodstream, which is necessary to create the death. And so, whereas initially, historically, in Oregon and on to about 2016, we always thought that the weakest, most wasted patients would be the quickest patients to die. But as it turns out, when you look at the data, these patients, the weakest and sickest, are in fact at risk of a prolonged or complicated death. And the reason for that is that if the patient's skin and muscle and fatty tissue look like what you see in this photograph, well, what do you think their intestinal tract looks like? And the answer is this, is that normal intestinal tracts, as you see in the upper left, they have these nice finger-like projections called villi that create a huge surface area and absorptive area for the medications to be absorbed into the bloodstream from the intestinal tract. But as the patient gets sicker and sicker and loss of tissue, you can see the absence of the villi in the lower right image. So the gut's efficiency in getting these medications in is very, very poor in the sicker patients. So Carol Parrott and I put our heads together and we started looking at all the factors that can potentially complicate or prolong an aid in dying death. And we came up with what's called the red flag checklist. You can download that on the Academy's website. It includes gut issues, swallowing concerns, concerns related to the medications the patients have been on, factors like obesity or having a very young, healthy heart, concerns about mental health and addiction. So we have this list now that is predictive, and we can do something about some of these factors so that we can now look at it and say, look at this. This patient is at high risk of having a long death. We tell the family, we tell the patient, and now they're making an informed decision and a knowledgeable decision about what may happen. Which leaves us with another question. And you all probably know this because this is one of the limitations traditionally of this law. What about patients who can't swallow? Patients who are too weak to swallow, usually from ALS and neurologic diseases, but also from being just too weak because they're dying, mechanical obstructions from tumors in the esophagus or in the pharynx, bowel obstructions, and even aversion to bitter taste. These are bitter medicines. Some people just can't take them down. And so traditionally, until 2016, the term ingestion and its associated words was interpreted to limit the practice of medical aid in dying to patients who could swallow the medicines. End of story. Occasional use of stomach tubes, but that was really, really rare. And so California, being radical and obnoxious people that we are, started asking some questions like, what exactly does ingestion mean? It was written by the lawyers. What does it mean to us at the bedside? And to get an answer to that question, we got together and wrote a letter to the California Medical Board and said, you know, we keep hearing about this word ingestion and everybody says it just means swallowing, but what do you think? And they wrote back to us in 2 days and said, ingestion really is any self-administration into the gastrointestinal tract. And we said, wow, that's interesting, because that opens up the possibilities of anything that gets into the gastrointestinal tract by the actions of the patients. Includes feeding tubes. Of course, it includes swallowing, but feeding tubes, ostomies like colostomies and ileostomies, which are surprisingly common because of cancer patients, and rectal or enema self-administration of the medications, which I will talk a little bit about more. And so what happened as a result of that medical board decision is that swallowing, patients who lost the ability to swallow for various reasons are now an entire category of people who are eligible for medical aid in dying, whereas before 2016, they were not. So look at how we're improving working within the realm of the law. This is the tube on the upper left. It's a Foley catheter. It's thin and small, thinner than your pinky. It's gently inserted into the rectum, and then a syringe is attached. The patient then has to administer the medications. And as you can see here, if I push the right button, there he goes. And so that's the self-administration of medications into the rectum. And it works highly effectively, as much so as oral administration for all practical purposes. And any myths that you've heard of, this is uncomfortable and you have to contort yourself and all that, just they're myths. This is a very comfortable procedure. It may be a little bit more embarrassing for the patient, but we usually clear out the room of relatives and all that, put the catheter in, then cover the patient up, and nobody even sees the catheter and what's there. It has opened up a huge number of patients who otherwise would be ineligible now to be eligible for medical aid in dying. Let me move on so I'm not taking up all your time and you have questions, room for questions. Some of the pragmatics that we've learned since 2016. It used to be the style that the most essential component, and in fact, the definition of aid in dying used to be the writing of a prescription for a lethal medication at the request of the patient. That was the very definition. The writing of a prescription is what aid in dying is. And but the writing of a prescription is a single brief moment in time, a static moment, whereas dying is a dynamic process that changes and moves up and down and has all these components. And since 2016 or so, and it was somewhat improving before that, but the real change has happened that we don't now think of aid in dying as the writing of a prescription, but it's changed to the taking care of a patient. So we follow patients over time. We don't just hand them a prescription and say, take this whenever you're ready. We're with them as the questions and the process evolves, and it's complex. The idea of if and when to take medications to die is not a simple question, and it's not about just being handed a prescription. It's about being with your clinician and thinking this through as best as you can with the best evidence you can. So we've changed to a dynamic process of following patients rather than just writing prescriptions as our job. Really common question comes up about vomiting, and vomiting was a very significant issue for many, many, many years. And the question comes up, will my patient vomit the medications? The answer is, as it turns out, when we looked at examples of vomiting, the most common reason that somebody vomited the aid in dying medications, which is not a good thing, obviously, is that they had vomiting before they took the aid in dying medications, meaning part of their dying process was to have nausea and vomiting. And then, of course, if we gave them aid in dying medications, they were vomiting beforehand, they're likely to vomit our medications too. So lots of things have been learned about the importance of controlling nausea and vomiting before the aid in dying day as aggressively as possible. And I'm not going to go through all the permutations of how you do that, but we really started learning one thing about this medicine called dexamethasone. It's a steroid medication that is probably the most effective of anything for nausea and vomiting at the end of life and the associated gastric paralysis, stomach paralysis. So when you want to really get nausea and vomiting under control, because the patient is going to soon take medical aid in dying medications, dexamethasone has been learned to be a wonderful thing. And then it has this great side effect profile, which is that in the few days before aid in dying, it makes the patient just feel better. You get more energy from dexamethasone, your appetite improves, and you just feel a sense of well-being, which is a lovely gift a few days before you're going to die. A case history: 69-year-old female with pancreatic cancer, patient of mine, has intractable nausea with some vomiting. She's unable to get out of bed because she is so weak, and she's rapidly approaching the day of her death, even if she doesn't take aid in dying medication, so she's sick. She's opting for aid in dying, but she's decided on a week or two in advance that she wants to take the medications when her family could be there. And she has one final request of me and her family. She grew up on a farm, and she wants to pet a cow one final time. But she's no longer on a farm. She lives in the suburbs. Her bed's on the second floor of her house. And so it's kind of hard to get the cow up there. We need to get her down to the cow. We start her on 8 milligrams per day of dexamethasone. And 2 days later, and so the advantage is her nausea and vomiting stopped. We were following her not just as a prescription, but as a patient with needs. We got her out of bed, we got her downstairs, she got to pet her cow, and maybe it went a little bit too far with the dosage of dexamethasone because she got a little carried away. And this happened a day later, and a week later she died. Not, by the way, by aid in dying medications, and that's irrelevant. She had a good death. Okay, another change: attending deaths at the bedside. The pattern in prior history was that it was, for many, many years, felt that, and rightfully so, that the aid in dying moment when a patient takes medications is a private moment between the patient and their family. And that made a lot of sense for a long time. Families just didn't want to crowd or clinicians or anybody there. That was the thinking. But once we started seeing higher numbers of taking care of patients clinically, we started realizing that the experience of aid in dying when nobody else is there but the quietness of the family is tremendously frightening. Most families were telling us that we are scared about this day. We don't know how it goes. We have no experience. We have to mix the medications. We don't know what to look for if there are problems. And we are scared and worried instead of being there to be loving to the one who's passing away, who's dying. So loved ones, I believe, and we've learned this, I think, and it's become more clinically significant, loved ones are there to be loving, not to be medical aid and dying technicians, and not to be frightened about what's going to go on that day because they've never experienced it before. And so the trend has been really accelerating over the last 6 years to have either doctors or hospice clinical staff, nurses, social workers, chaplains, end-of-life doulas, volunteers who are trained, somebody who knows the procedure to be there to guide the family along quietly. We don't sit there and have parties, obviously, but most families, when offered this option now, say, that's wonderful. We can be there and be more relaxed. Please have somebody there with us. And to give you an idea of how significant that's become over time, the data from New Mexico just in last month, because they reached their first anniversary, New Mexico is the newest state, so they're taking advantage of all of the learning that we've all done beforehand. Out of the first 100 deaths in New Mexico, 98 of them were attended by a clinician to be there for the family because the families wanted that when given the option. 98 out of 100 in the newest state. Oops, I'm stuck. There we are. All right, let's get to reality here. As Faye said, access to medical aid and dying remains difficult. I'm not going to beat around the bush about that one. Many, many, many patients, and I hear from them all the time when they finally find us, say, it's been so hard. I asked my oncologist, I asked my internal medicine doctor, I asked my family practitioner, and they all said, oh, you know what, I'm not comfortable with that procedure. And let me define that for you. What they usually mean is they're not saying they're ethically uncomfortable. What they really mean is that this is something new. I'm not trained in it. I'm going to need some education about it, and I'm not comfortable doing a procedure I'm not trained in. So these patients are having a hard time finding clinicians, finding doctors who will work with them. And so the Academy has started up, it's 2.5 years old now, excuse me, a patient to doctor referral system. Any patient, and that includes people who are talking to you folks, you guys are involved in this issue, any patient or any representative of a patient can fill out the Academy's intake form, and we will get all the information we need, their terminal diagnosis, where they are, who their doctors have been, what healthcare system they're in. And we've had more than 400 requests across the country now from patients who cannot find a clinician and who are looking for a doctor to work with. And our batting average of over 400 cases is 100%. We have placed every single patient who has approached us looking for a doctor. We have placed them with a doctor if their request was appropriate. And so access is still a significant problem because not everybody knows about this system, but we have a system in place, and please use it and please recommend it to other people. To wrap up, I would be remiss if I didn't talk about SB 380 in California. SB 380 started in January 1st. It's the law in California that modified the original End-of-Life Option Act. And as I said before, I always get a little concerned when we look at new ways to do things on a legal basis, because then everybody sort of thinks, oh, I have to follow this aspect of the law, and they forget about the patient. But in SB 380, there's a lot of clinical significance to this, to the point where the Academy has a session, you can use that link, talking about the clinical perspective, not just the legal aspects. It's a law, it's hard to read, but we're talking about what happens at the bedside now that we have SB 380. And I'm going to highlight only a couple of things, and then you can, by all means, feel free to watch our webinar about that. First of all, most significantly for clinicians and their patients, the waiting period is decreased from 15 days to 48 hours. Let me really emphasize that it is very rare to have somebody come on a Monday and get aid and dying on a Wednesday by 48 hours later, because that's very difficult to do. You have to examine the patient, get the medicines and all that. Nonetheless, for emergencies, that 48 hours is very nice. It got a little bit frightening to clinicians to think they had to complete the whole process in 48 hours. That is not true. It's not mandated to do 48 hours. It's just that you can if you need to. Most patients still fit in the 15-day to even up to 6-month period before they take aid and dying medications. Okay. SB 380 also requires that every healthcare organization has to have an aid and dying policy ready and clearly available to the public. Compliance with this, as Faye knows, is not really wonderful yet, but it's a good law to have, and it's a way to make sure that if you're working with a healthcare organization, you can find out their aid and dying policy. It's not quite in progress yet, but it will probably get there over time. We're working on it. So to summarize and conclude, since 2016, aid and dying has become evidence-based medicine with good clinical bedside care based on science and data and based on compassionate staying with patients, not just thinking about writing prescriptions. There have been major changes. And so, there's my puppy on the right. I have learned to get along with my puppy. She's still shy and she still barks more than I would like, but we're working on it. It's getting better all of the time. She is the dog that I have, not necessarily the dog that I want. And that sometimes is the best you can do. We have our law about medical aid in dying, and the goal of the Academy is to make that law work as best as it possibly can for everybody involved with it. Thank you. That is the website for the Academy, acamade.org. There's lots and lots of information. And I'm going to invite you now to we had the 2020 conference that Faye and I talked about. I'm going to invite you to the 2023. Now, there's our website, nccmade.org, the National Clinicians Conference on Medical Aid in Dying. Please come. Join us. We're going to have an amazing array of 2 days of speakers about the clinical aspects of medical aid in dying. I'm going to stop sharing and become a human being again. Thank you, everybody.
Great presentation, Dr. Shavelson. Wonderful. We always hear vaguely about the process, and so to get the kind of details that you offered, I think was just marvelous. I know that some of our audience, both our audience in person here and our audience on Zoom, will have a few questions. If you can take a few minutes to answer some of those questions, I'm sure all of us would be grateful.
My pleasure. That's the fun part.
Okay, great. Let's start. Is there anybody here in the audience that has a question for Dr. Shavelson? If you have a question, raise your hand and we'll bring a microphone to you. I see somebody over here.
Terminology here. The goal, it seems, of this practice you have is death of the patient. I mean, that's what you're trying to achieve that. In other settings, like a hospice setting, the goal is to keep them comfortable, but not to kill them. And so how does that play out? You could almost say if your goal is to kill somebody, that's murder. I'm not saying that. I'm just thinking about how this terminology plays out.
Well, let me go to the philosophical underpinning of your question, if I may. As I said, we no longer think of this about writing a prescription, but we follow and care for patients along with hospice, and a good 90% of the patients that we take care of are participating in hospice. And so we take care of those patients as part of the end of life team. And so our goal is actually not to have them take aid in dying medications. Our goal is for them to have all of the choices that are available to them, including they can say, well, I've got the medications, that feels good, but I've decided not to use them and I'm as happy as a clam. My goal is not to stop their heart intentionally by my action or even theirs. My goal is to make them, and in your terms, you're absolutely right, is to make them as comfortable as possible, provide the best medical care. And that's kind of what I've been saying, is we have moved from the idea that the goal is the writing of the prescription and the taking of the medications. If they choose on their own, that's their choice. Our goal is to let them have that choice, make them as comfortable as possible. If a patient calls me up and says, I want aid in dying medications at my bedside on Friday because I'm in so much pain, my first goal is not to get them the aid in dying medications, it's to get them good pain medications. And then revisit the possibility of dying on Friday if that's what they want. So we have become not aid in dying doctors, but end of life doctors. And that's a very significant change. And thank you for pointing it out, that if I wasn't clear about that, that's what I mean by the focus has moved from writing the prescription. In terms of terminology like kill, well, kill is not, and nor is suicide. When a patient self-administers medications at the end of their life, they are administering the medications. There's no killing happening. We are working within legal parameters to provide those medications to them. But killing is an inappropriate word, death is an appropriate word, but it always happens. And suicide, by definition and by the law, and I can get into all the reasons why suicide is the wrong term, but I won't at this moment, but there are many. And so medical aid in dying, death, and all the rest, the terminology doesn't go towards killing because there is no killing. Next.
Is there another question here in the audience, in-person audience? Okay, I see somebody here and got their hand up, and now she has the microphone.
At the risk of being very cynical, what is the risk of our current Supreme Court making decisions to eliminate yet another freedom that many of us have taken for granted?
I don't know. I tend to like to speak about things, as you may have guessed, that I know about and I have data about and all that. And this court is mystifying to me, as it probably is to many, many people. There is a risk because precedent, which happened in 1997, there was a Supreme Court, as you know, that we all lost by 9-0 in 1997. And that set a precedent, which is the Supreme Court said there's no constitutional right to medical aid in dying, but the states can do it if they wish, and they won't, and the court won't interfere. So we have a good precedent from 9-0 in the Supreme Court saying no national right, but the states have the right. Whether they will, as they did with Roe, overturn that precedent or not, I haven't the slightest idea. I tend to be optimistic about it because we're small fry compared to abortion. I don't think it's worth, they think it's worth their time, but I'm an amateur at that business. And I think that I would leave that question to the advocates and politicians and all the people who are going to have to deal with it. That's not me. I'm a bedside clinician.
Okay, I saw somebody else, I think, who had a question here. And then after we finish another question at the most here, we're going to give people on Zoom an opportunity to ask some questions too. So yeah, go on ahead.
Thank you very much. Who makes the determination of the 6-month limit or the 6 month until death so that the process can go forward?
The aid in dying prescribing, there's somebody called the attending prescribing physician. In the law, it's called the attending physician, but I always use the word prescribing after that. The person that you go to who will be the attending physician who can prescribe the medications if appropriate makes that determination. They use lots of information. They can get information from the oncologist, they can get information from hospice, but in the end, it's up to the attending prescribing physician based on the End of Life Option Act, as well as the consulting physician. You need 2 physicians who agree on that. We do seek input, of course, and we use chart review and we get lots of information to ascertain that, but it's our call. We make the decision.
Question from our in-person audience, and then we'll go to the Zoom questions. Is there one more? If not, okay, let me ask if Pam has perhaps a question that came from the Zoom audience.
Thank you. 2 questions actually is, Dr. Shavelson, you didn't mention the name of your new doggie, and I'm curious about that. And secondly, you stated that you don't want to stop a person's heart when they're still conscious, and I'm curious about the reason for that. Thank you.
I'll do the last question first. It's the easier one. You don't want to stop somebody's heart because it's uncomfortable. It's not a pleasant death. I mean, if I could stop your heart right now, you would get dizzy and then you would slowly die over a couple of minutes and you would feel terrible during that interval. That's not our goal, which is why I say that it's somewhat difficult because we have to, the death must be comfortable, right? That's the goal. And so if you just give somebody something that will stop their heart, they're going to feel it and they're not going to feel well. And so to compound that a little bit, the effect of the sedatives that get you to sleep before your heart stops and unconscious is actually quite pleasant. So what in fact, I frequently make note of the fact that I tell patients that as you're going down and getting sleepy, you're going to feel a euphoria. And get into it. It's a pleasant sensation. Don't fight it. The euphoria comes from the enormous dose of medication of the sedatives, which is morphine and phenobarbital now, and that, and diazepam and Valium. And those medications get you a little bit high on the way down. It's only for a minute or so, but it makes it so that one of the commonest last words that I hear from a patient, the last thing they ever say in their lives is, wow. And that's much better than stopping their hearts where they go, oh, that's the answer.
Thank you.
Sure.
What about your doggy's name?
His name, Corvida, Corvida, combination of coronavirus and life. He's a
Thank you.
he's a pet.
Yes, thank you, Dr. Shavelson. I have just a couple of questions, three actually. I was wondering what your opinion might be regarding the Canadian law.
Okay, two. You want to do them all first, or you want me to answer them?
Okay, no, I'll give you the three questions. At present, my understanding is that our law here in California does not accommodate people who are terminally ill, who have maybe a life expectancy of, let's say, a year. What do you think about the chances of being able to get rid of that 6-month limitation? There are many, many people who are beyond the 6-month limitation and still suffer, still will be dying. And just wanted to get your thought on that. And the last one is the last slide that you showed with your organization. At the very bottom, there was a little logo for with Death with Dignity. Are you affiliated? Is your organization affiliated with Death with Dignity?
Good question. Okay.
Thank you.
The last one's quick, so that's easier. And the other two have the same answer. Death with Dignity is co-sponsoring, co-facilitating the conference with the National Clinicians Academy on Medical Aid and Dying. They did so for the 2020. So we're not formally affiliated as two organizations, but we are co-facilitating this conference. And that's a great thing, I think. Your question about the 1 year versus 6 months is 6 months is the dog that I have to learn to love. And that's what I got, and that's what I work with. And yes, things could be, there are many things about the End of Life Option Act that could be improved. SB 380 addressed some of those, and the political atmosphere was not such that they could do much more than what they did. But I've got the dog that I love, and I work with it, and I want it to be as good as possible. And I leave it up to you folks as an activist and all the rest to make it better over the years. But what I'm doing is making it better within the parameters of what we got.
Thank you.
Canada, I'm going to be agnostic. Yes, they have a very, very different law. I'm going to stay in my lane. I think that there are obviously some problems with the Canadian law, and obviously some wonderful things about the Canadian law. And I try not to talk about Canada, the Netherlands, and Belgium, and whether it should be in Scotland and all that, because I'm a clinician. I work with patients. I'm not a politician or an advocate.
Thank you. Just a wonderful presentation. In previous meetings here with our Hemlock Society, it's been recommended to us that we talk with our doctors about end of the MAID in California. When I did talk with mine, she said she was uncomfortable making that 6-month designation, that you have 6 months to live. And she said it's very difficult. Under the new law, it says, let's see, that the 6-month designation must be made by an attending physician. What if you can't get an attending physician to make that 6-month designation? And then a real quick second question. The new law says that the healthcare institution must have a policy. Must that policy be on their website? And thank you very much.
Yeah, good questions. I'll take the second one first, because that's, again, the easy one. Yes, the policy must be on their website. It's in the law. Then the person who cannot find the attending physician, well, the attending physician doesn't just make the prognosis. The attending physician is responsible for the whole aid and dying process. And yes, there are times when somebody can't find it. That's what I was talking about at the end of my presentation, is that access. is difficult for some patients who still can't find someone. And it's not uncommon for a doctor like the doctor you just talked about to say, I'm uncomfortable with this prognosis. What we try to do with those doctors, we try to educate them because they're usually uncomfortable because they haven't been taught that aspect of medical care, and we teach them. But nonetheless, when access is difficult, there are various routes we're trying to improve access by educating the doctors. The attending physician, which you mentioned in the law, which I call the attending prescribing physician, is the one who supervises it. And you know, if a doctor isn't willing to give you the prognosis, and you can't find a doctor to get the prognosis, well, you also don't have a doctor to follow you and prescribe medications and be your doctor for 8 and 9. So the answer to your question is we are trying as hard as possible to make a better system so that anybody who wants to consider, notice that I don't say anybody who wants aid in dying, I say anybody who wants to consider aid in dying. You don't really know if you're going to do aid in dying until you get the medicines in your mouth. And so everybody that I work with is considering medical aid in dying. They're my patients, I take care of them. And if they choose that route in the end, fine and dandy. And if they don't, that's fine too. So if you're considering medical aid in dying and you need a doctor, we will find you a doctor at the Academy, 100% sure, right? So far. And yes, it's a problem, but it's not a question of just finding somebody for prognosis, it's finding somebody to be your aid in dying doctor, period. And that's the attending prescribing physician. And we have access to those docs because we're wonderful. Next question.
My question is, I know it seems like I'm in California. It seems like there are a small number of doctors who are the ones that people go to. And my first question is, does health insurance ever pay for that, the physician? And then the second thing, is there an average amount, or is that vary dramatically in terms of somebody that would be at the bedside helping you?
Let's take insurance first. First of all, you have to understand that most of the patients who do this, the majority, but not all, certainly, are over 65 and usually have Medicare. Medicare itself does not cover this. This is a state law, and Medicare is a federal policy that doesn't participate in medical aid in dying. So Medicare does not cover this at all. Most insurance companies, some rather, say that they do cover it, but since there's no diagnostic category, we bill insurance companies based on categories and coding. And there is no code for medical aid in dying, so it kind of has to slip around to end of life care. But in some ways, some of the visits are included. The actual attendance on the day of death is not included by almost any insurance company. The medications themselves are included by some, especially Kaiser, which is obviously a large insurance policy in California, but Medicare doesn't cover it. Medicaid, oddly enough, does cover it because Medicaid is statewide. So it's varying. I would say that 90% or more of patients have no coverage whatsoever and pay out of pocket, depending on what the doctor charges and the medicines fees and all the rest. It is an out-of-pocket procedure because the insurance companies and Medicare are not playing with us. The question about bedside attendance, the data, and I'm going to just say the data of the state of California, which I don't find particularly reliable, and that's too long a conversation to go into to tell you why I don't think it is, says that about 45 to 50% in California of deaths are attended at the bedside by a clinician. In New Mexico, it's 98% right now. In Oregon, it's high. In Washington, it's extremely high because they have a huge volunteer network, and those are trained clinicians at the bedside, and it's probably close to 90% in Washington. So I don't think that the data in California is accurate, but it runs between about 45 and 50% of clinicians at the bedside. I think it's actually much higher.
Could I ask you one more thing about that?
Sure.
Just the cost of if you have a physician at the bedside. I've just heard of different costs that kind of like I don't know if there's really such a thing as a package deal, but when you contact the person, it kind of sounds like that to me. So if I were to contact a physician and they say, yes, and they'll work with me, is there is there kind of like because that's what I've heard of, a package cost?
Yeah, there is. I mean, and it will vary as much as anything else in the world. I'll just tell you that the package, which is usually from from the first day you meet the patient to being, and that's the way I ran my practice when I was doing this as a practice, was there's a standard fee for everybody. And it goes from the first time you meet them to whenever they die, whether they die by aid and dying or not. And if they do die by aid and dying, you're at the bedside with them. And so that's the package deal. The variation is from $0. Some people do this voluntarily because they're good at heart, or because they have a sliding scale that goes down to 0 and do pro bono work, as I did, up to about $8,000, which is the highest that I've heard, and everything in between. I would say the average falls between $1,000 and $3,000 roughly for all care related to aid and dying.
Oh, okay. My question is regarding oh, anything for dementia and Alzheimer's disease, how difficult it is to get involved in, especially in California. Is anything being done to make it easier to be included in the whole process of death with dignity, quote unquote? Because having Alzheimer's, there is no cure. We are not going to be able to, and you don't know how long the pain and frustration is going to be lasting. So what is being done to improve that so we can be included when it's needed? Thank you.
The answer is much is being done. And at the present time, there is no accommodation. And I'll say this quite clearly: if dementia is your only disease, if you have dementia and cancer, you're probably okay, depending on the cancer, of course. But if dementia is the primary disease that you have and you're dying of dementia, you're excluded from medical aid and dying by any legal practice in the United States today. So you're correct. It's difficult. There's a lot of suffering with dementia. But there is no way in the present context, which is where I work, to include patients with dementia if they are, remember, they have to have capacity to make their own medical decisions, to participate in the legal practice as it is today. And so if you have dementia and you still have capacity to make medical decisions, you don't have a less than 6-month prognosis. And if you do have a less than 6-month prognosis from your dementia, you're too demented to have capacity. And so that catch-22, we are restricted by the laws. As I said, these laws are not perfect. I cannot help in any way, nor can any physician participating under the law in the United States work with patients whose primary diagnosis is dementia. Is anything being done? Well, again, I'm out of my lane on that. There are a lot of people saying that they're working on that. They would like to have that happen. The reality of the California legislature or other legislatures moving into the realm of dementia in the near future, which I would include, let's just say 10 years, strikes me personally as an amateur in the politics of all this, highly unlikely. We got enough problems passing aid and dying laws the way they are. And so we're still stuck with the dog that we love. And probably we have to work with that particular law the way it is for the next 5 years at least, before somebody starts talking about changes actively. Are there advocates in that business who are trying to do so? Yes. One of which I believe is Hemlock Society of San Diego, and more power to them. But in the present context, dementia is excluded, period.
One thing I'd like to add to that, yes, here at Hemlock Society, of course, we believe the law should be expanded. We believe that by eliminating people who have dementia, we're eliminating many, many, many hundreds of thousands of people that could benefit from death with dignity. And we are, as I speak, working with some folks in our group who are attempting to begin to at least educate lawmakers on the importance of expanding that current law. But I think Dr. Shavelson is right. Given the current environment, it's a very long-term struggle. And I expect that it will be many years before we make that change, but we have to take the first step, and we're doing that. And so keep an eye on your emails, because we'll send you some emails about what we're doing, and maybe even ask you to get involved and help do that. So any other questions here in person? I see one person with their hand up back here.
Just following up on that last answer. So all of the work that I put into an advance directive for dealing with dementia, end of life, that goes out the window. It doesn't matter. Whatever I said, if I wind up with dementia, and even though I have it in my advance directive that I choose aid in dying, I can't, doesn't matter. I might as well not have done all of that work. I mean,
Yeah,
that's what I'm hearing now.
your last sentence is correct. You cannot put aid in dying, you can put aid in dying into your advance directive, but it's not legally binding and nobody will follow it. It's presently illegal. Unless you have the capacity to make the decision at the time of your death, then we cannot legally give you medications to die. But that doesn't mean that advance directives aren't powerful tools. You can say in your advance directive that you don't want a feeding tube, you don't want to be intubated, you don't want to have CPR, you don't want to be fed unless you have desire for food. There are lots of things you can say that are related to dementia in your advance directive, but they don't include medical aid and die.
Oh, thank you. I just one other question regarding oral ingestion. SB 380 says that the attending physician needs to let the patient know of the risks involved with taking a drug orally. I've tried to find some information online about those risks, and I haven't been able to. Can you tell us a little bit about what kind of risks are involved with oral ingestion? And would a person like a nurse practitioner, for example, would they be allowed to participate so that if something happened, they might be able to help?
The second part of your question is complex, but I'll deal with the first. Yes, there are in medicine, no matter where you are for anything, there's a risk. There's a risk that you can take these medications, and as I noted in my presentation, you can vomit. There's a risk that you take these medications, and if you happen to have a cancer in your brain, that you might have a seizure while you're unconscious. There's a risk of a prolonged death, which I talked about extensively, which I consider to be a true risk in that it's unpleasant for your family, although not for the patient who's quite unconscious by that time. So we go over these risks with the patients, and if you go through our educational materials for clinicians, there are many sections where we talk about how to talk about these risks, especially if you look at our 3-part nursing protocols on our website, at the Academy's website, and you look under the clinicians tab for continuing education, you'll find actually lots of information about that. In general, the risks of oral administration, if you control beforehand nausea and vomiting, are fairly minimal. These risks are rare, less than 1%, but there is no medical procedure that is risk-free. And I will say this not with tongue in cheek. We have not had the case yet where somebody took the medications. I know of one case in Oregon, but in my experience in California, which is pretty extensive, we haven't had a single case where somebody took the medications and did not die. So the risk of not dying and waking up is virtually zero. Even in the one near catastrophic case I heard of from another state where a lot of the medications leaked, there were problems with the medication administration. That patient took 26 hours to die, but remained unconscious. One of the things that I really like about the present formulary, which includes phenobarbital, is that we know that even if they don't die for 3 days, which hasn't been reported yet, but we know that they'll stay unconscious for that time. So the crucial thing with the risk of a prolonged death is we want to know that the patient's going to remain in a coma until their heart stops. And that is true. So yes, there are risks. I don't mean to minimize them. They're extremely rare. It's an extremely safe procedure. If by safe, you understand that our goal is death. Some people make fun of me when I say a safe procedure, but you get my idea.
Yeah.
I think we're kind of at a point where time-wise, we need to let Dr. Shavelson off the hook there. He's been very generous with his time, and we appreciate it immensely. Let's give him a hand for a wonderful job. And
thank you so much for inviting me. And a final note is congratulations. You guys are amazing.
Thank you so much, Dr. Shavelson. And the second segment of our program today is our own Faye Gersh, who's going to tell us a little bit about the history. You know, we are celebrating 35 years as an organization. Not many organizations of this sort last 35 years. And as I said in my intro, a lot of that has to do with the fire that this woman on the stage with me carries inside her for this issue. She's going to tell us just a little bit about the 35-year history of this organization. And of course, I'm sure she'd be happy to answer any questions that you have.
John has some slides. I don't know if we want to see them, except, first of all, I want to clarify one thing. A lot of people think that I'm the founder. I am the founder of the Hemlock Society of San Diego, which was founded in 1987, 35 years ago. But the National Hemlock Society was not founded by me. It was founded by, is there slides in the back of me? Derek Humphrey, whose picture should appear momentarily. There he is. How many of you have heard Derek Humphrey speak or know who he is or read his books or something? Okay, please, because I'm happy to take the credit, but he deserves the credit. He has written all the books. It was he who helped his wife die and started this whole idea. My daughter is pointing to something behind my back, which I can't see. Let's see how I do this. I get crooked, I guess. Okay. Oh, it's going too fast. Maybe I just better talk, come on. Those are all the books, well, at least most of the books that Derek Humphrey wrote about the right to die. Before that, he was a journalist in Britain. He wrote for the Sunday Times. He wrote books at that time, but not about the right to die. But then his young wife got terminal cancer, and at some point asked him if he would help her die. I have to say that Great Britain has been very, very slow in passing any right to die laws, continues to be very slow. He did help her die. He found medication from a sympathetic doctor and wrote this book, Jean's Way, about helping her die. And so many people from all over the world responded by saying, how did you do that? How did you have the courage? How did you not get caught? How did you find a doctor? And he realized he was, by that time, had moved to Los Angeles and Santa Monica, to be specific, with his second wife. And because of the popularity and the proceeds from the book, they founded the Hemlock Society, National Hemlock Society, in 1980. National Hemlock Society under Derek had chapters. I got involved. Am I on there yet? I don't know. Thank you. Kamala, my daughter from Australia, is back there. She's very helpful. I got involved in 1983 I was on the ACLU of Southern California board, and we had a request from this woman, Elizabeth Bouvier, who was almost a quadriplegic from cerebral palsy at birth, 28 years old, had admitted herself to Riverside Hospital and asked to die by refusing to eat and drink, which is now a very common way to die. But back in 1983, it was not permitted. And so she contacted the ACLU to take her case challenging that law. And I was a forensic psychologist, that was my profession, and so the defense team asked me to evaluate her to see if she was mentally competent, which she absolutely was. We lost the case in the trial court. She won 3 years later, but for her, that was a very painful way to die, and so she died later, but not that way. What's next? That was 1983. In 1986, I put together a conference at UCSD, co-sponsored by the ACLU of San Diego, Southern California, the California San Diego Bar Association, the San Diego Medical Society. And we invited a number of people from all over the country to talk about the right to die, pros and cons. And one of the people I invited was Derek Humphrey, whom I had never met before, but who had started the Hemlock Society 6 years before. And I have to say that I still remember practically every word he said, because it was very startling to me, even though I've been thinking about this now for 3 years. I mean, he said that there should be a celebration of life after you die. You should die if you're gonna, you should have help in dying, preferably from a doctor. If your suffering has become unbearable to you, your family, your friends should be there if you want. It should be like a birth. It should be something to celebrate. It should be gentle, peaceful. It should not be violent. You should not jump off buildings. You should not die in your car alone. I was really impressed. So during the break of our conference, my doctor was there actually, and the three of us had dinner at lunch, and I said to Derek, shall we start a chapter here? And he said, sure, by all means. So the following year, 1987, 35 years ago, we started the Hemlock Society of San Diego. And the next year, I have to say thank you to some people that are now dead that were so immensely helpful for so many years in the beginning of the Hemlock Society of San Diego, some of whom you may remember. I think Ken Kaplan back there was with us all this time. I have to say, Sally Troy, who is now deceased, I'm sorry to say. How many remember Sally? Oh, good. A saint. She was our vice president after I became national head of Hemlock. She took over as president. She and her husband, Arthur Metcalf, almost singly financed our campaign in 1991. Unsuccessful, but without them, we would have had nothing. Sally was the person who helped us in 2 initiative campaigns, collect signatures, and some of you may be victims of her mercilessly saying, please come in front of Vaughn's grocery store on Saturday with your ironing board and collect signatures. Sally Troy and Arthur, both deceased now. Dr. Mitz Tomita, many of you know Mitz is still alive and well, currently in Seattle, but will be back here. And he was our medical director. Elizabeth Robertson was our hostess. She lived in Mission Hills. She hosted our meetings for I don't know how many years with her husband, Tom. Michael Evans was our legal director. And you're looking quizzical, and I don't know either. Michael was very sick at one time, and I don't know truly whether he's alive or not. And Jim Christensen, who died last year of a brain tumor, was our treasurer for 13 years. I'm just saying this because, first of all, they mean a lot to me, but the fact that these people would work for us so long, no salary, of course, and keep us going and do all the exciting things that we did in the first years of our existence. So during the course of our existence, we've had, our mission is to educate the public about the options that are available to them. Lonny talked about the End of Life Option Act here in California, which is the law. We talk about lots of other ways that people can find some kind of peaceful ending in their lives. We talk about what goes on in other countries. We talk about voluntary stopping eating and drinking. We talk about going to Switzerland. We talk about a lot of things that came up here, but Lonny's not going to talk about, but we are. We're going to tell you anything we know about how to achieve a peaceful death. I was the founder, by the way, of Final Exit Network, which is another alternative that stemmed from Hemlock. I was president of the National Hemlock Society, where we started the Caring Friends program in 1998. In 2005, the National Hemlock Society was dissolved by its board. The Caring Friends program became, service. The National Hemlock Society dissolved. I think we are the only remaining Hemlock Society, even though there were some like 90 chapters. There aren't anymore, but we are it. We are not a chapter, of course, anymore. We're autonomous. So we have public meetings every other month, public meetings and panel discussions on all sorts of things, such as these topics, and lots more because we've been doing this for 35 years. We also have people from other countries talk about the law in Amsterdam, in Holland, the law in Belgium, the law in Canada. Catherine Tucker, who was the legal director of Compassion and Choices, Rob Rivas, who was the legal director for Final Exit Network, All of these people have come here. I hope that some of you have heard many of these speakers, and there will be lots more because, as you can see from Lonny Shavelson, the field is burgeoning with brilliant, courageous people, many of whom are doctors, I'm very happy to say. I'm very proud of our Right to Die film series, which has been going on for, I think, about 6 years. Started before the pandemic. And every other month, when we don't have a lecture or panel discussion, we show a Right to Die film. How many of you have been to our Right to Die films? Fess up now. Okay, that means some of you haven't. We don't do them on Zoom because it's too complicated, although we started having just the discussions on Zoom if you can find the movie, which is not so easy. And our next one is How to Die in Oregon. Some of you may have seen that. It's not a new film, but because of Lonnie's presentation and because we're talking about the End of Life Option Act, you should know how that law works in Oregon first, and of course now in California and 9 other states. What else? We've been very active in the World Federation of Right to Die societies. I and all of us, I think, are firm believers in looking at right to die all over the world. The laws have varied tremendously. The laws have changed even in the past year. The law was passed in Germany, Austria, and I said that, New Zealand, a few other countries. So it's happening all over the world. And we have gone to World Federation meetings. The next one will be in November in Toronto. Not the best weather, but anyway, I'll be there, and some of us will be there. We co-hosted several World Federation meetings, and we're very proud of our contribution. I was president of the World Federation, very proud of our contribution to the World Federation of Right to Die societies, because this is an international movement. It is not San Diego, it is not California, it is not the United States. It is around the world where people want the right to have a peaceful death. And I think on that note, I want to introduce our wonderful board of directors. I don't know where everybody is, but you met Barry Price, our president. Ken Watson is sitting back there. He may be our oldest board member at almost 101. Janet has done a lot for today's meeting. Greg Knox back there, technical and other director. Barry, Christy is not here, but she's been very helpful. You can look at a tape that Christy did about her mother going to Switzerland, her mother with early dementia. Very important that she did that. And who else? Who did I forget? Okay, me and Greg, yeah. So 6 of us on the board. We welcome anybody who is interested in serving on the board. And we hope that we'll be around for another 35 years or even better. We hope that in the next 35 years, we will not have to do what we're doing now, and that is campaign for a better law. So we're doing a couple of things now, thanks to Pat Fisher, who's our first executive assistant. Pat's looking at hospice's policy on aid in dying. She could tell you lots more about this, that hospice is very reluctant, hospices in San Diego and everywhere, very reluctant to say whether they will do aid in dying in their hospices. It's very important for us to know these things. So she is very patiently trying to get this information to us. Christy, who's not here, is working with a group trying to change the law, to expand the law in the ways, where's my nice slide on how to expand the law? There it is, yeah. So of course, eliminating the terminal ill requirement, as you pointed out here, the terminal ill requirement is archaic. No other country requires that you have 6 months or less to live. It even says nothing about suffering. It's a stupid thing. So we'd like to change that. We would like to have alternatives to self-administration. As Lonny said, it's not easy to require self-administration. Canada has lethal injection. Many countries have lethal injection, especially if you can't self-administer. And so that needs to be changed. As you pointed out, dementia, there are solutions to dementia now, but they're not great. But the law does not permit any help for dementia, and that needs to be addressed. And right now, it's only doctors that do this. In Canada, there are paraprofessionals, and in New Mexico too, paraprofessionals who can help make assessments of people and actually administer the drugs to people. So that's got to change. And in Canada, there's of course directives that you can fill out saying that if you do lose your mental capacity and you have met the requirements for aid in dying, you can still get aid in dying. Not here, but in Canada, yes. But you can't go to Canada unless you are a citizen and entitled to health care there. And what Lonny talked about was medical means, medical aid in dying. That's nice, but it's not the only way. And when I started the Caring Friends program, and when I was head of the National Hemlock Society, we looking at inhalation of inert gases. And that is the method that is recommended by Final Exit Network. And there are other non-medical methods that can be used. As we try to develop them, we will let you know. But medical aid in dying is one model. The Oregon model is now 27 years old, unchanged. So that has got to change, and we are working on it. So I think that's all I have to say, except thank you very much for coming today. Thank you for being supporters of the Hemlock Society of San Diego. And we have to stick to that cumbersome title, Hemlock Society of San Diego, because apparently when we merged with Compassion and Choices, they took the Hemlock Society. So we are the Hemlock Society of San Diego. When you leave us in your will or trust, don't forget that. Anyway, thank you for volunteering. Thank you very much for coming. Thank you for everybody for your support. I'd like you to meet my grandsons from Australia, Nikki and Toppy. Very proud of them. Okay, Janet, you want to say something?
Don't go away. You're not allowed to leave yet.
I get my champagne.
You sure do.
Okay.
Bring this woman a piece of cake and some champagne, please. Somebody.
Emergency rations.
Okay. So.
Oh, look at that.
Thank you, Camille.
My very daughter.
So, as Faye just told you, 35 years, and because of Faye, it's why we've been here for 35 years. So, to our dear founder, Faye, on the occasion of Hemlock Society of San Diego's 35th anniversary, we would like to both acknowledge and express appreciation for all you've done to promote the Right to Die movement. Because of the pioneers in this movement, of which you are one of the top, we now have medical aid in dying in 10 states and the District of Columbia. And while there's still much work to do, we must take some time to reflect on what has been accomplished to this point through sheer determination and perseverance. Those of us who work beside you are truly standing on your shoulders. With much gratitude, the board and members of Hemlock Society of San Diego, we got you a little something. So,
Thank you.
you don't have to open that now, but a little birdie sitting right back there told us that you very much like ethnic food. So there's a couple of gift cards to some restaurants in UTC that hopefully you can go to and enjoy. So we also reached out to some movers and shakers in this Right to Die movement and asked them if they'd like to participate in saying a few words about Faye. No, it's an honor. So here's a tribute to Faye Gersh by Derek Humphrey. Some people have assumed that Faye Gersh was the founder of Hemlock Society. That mistake is very understandable because Faye has long been a pillar of this organization and its philosophical principles. Since I founded Hemlock in 1980 and she came across in 1986, Faye has been the outstanding personality, worker, officer, and speaker. No one like her, unrelenting. Without doubt, she has been my alter ego. For years in the 1980s and 1990s, Faye and I were the only people in America willing to go on TV radio, and conferences and speak about our beliefs and aims for legalization. Not so rare now. She uprooted from warm San Diego to chilly Denver in 1995 to take the helm of the wobbling National Hemlock Society. Not only did she bring it stability as executive director and president, but with others launched the vitally important Caring Friends program. It's my dearest hope that Faye will continue to give us her wonderful, invaluable support for a long time to come. Derek Humphrey. There are a couple more. So does anybody here know the name Catherine Tucker? So she's a lawyer. She was the one that went before the Supreme Court and tried to get a constitutional right to die. So she wrote, "Hello, dear friends dedicated to end-of-life liberty. I've had the honor of working with Faye Gersh since 1990 in the collaborative effort to expand end-of-life liberty to include options such as aid in dying for those approaching end of life due to terminal illness. Faye has been a tireless and stalwart advocate in this effort. Faye has always had an open mind and open heart to work to ensure that those in this population are empowered with information and choices. Faye has appreciated that each individual make this journey informed by their own values, beliefs, and preferences. Supporting the individual on this journey has been her focus. I have been privileged to work side by side with her in this effort. Among all the advocates I have been privileged to serve with, Faye stands out as a remarkable inspiration. Bowing with gratitude for her leadership, Catherine Tucker."
That's Catherine Tucker. I'm standing in the shadows of these people. Catherine argued the case in 1997 before the Supreme Court of the United States. You don't beat that. I mean, and the things that she's done since then are remarkable.
But Faye, she bows to you.
Thank you.
So one more. How many people know the name Thaddeus Pope? Another lawyer.
Oh my gosh.
Another lawyer who works a lot in the Right to Die movement.
Another lawyer. He's the biggest legal brain in our movement.
Yeah.
Man,
Yeah.
Minnesota.
So he wrote, and his is short and sweet, and he wrote that. He said short and sweet, but for years, many distinguished elected officials, like Bill Clinton, explained how, early in their career, they met or briefly worked with JFK or RFK, and how that encounter inspired them for a career in public service. I view Faye Gersh the same way. I'm so impressed by the range of work in advocating for end-of-life liberty. I am grateful for being invited to participate in several Hemlock Society San Diego events, but most importantly, I am energized in my own academic and policy work by Faye's bright and shining example. So we all appreciate you, Faye, and all you've done.